Which one?
The one that says I'm sharing the bar at the top.
You can just cancel it. There's a.
I'm trying to look for, it's been irritating.
There's a word there, I think it says okay or something. You can just click on it.
I don't see that. I just see optimize for video clip. I don't know what that means. Mute, start video, security, participate. Oh, I don't see what that is. Anyway. Okay, we have a lot to discuss today. I'll give people a few more minutes.
Dr. Waweru?
Yes.
I think we can begin.
We can begin.
Yes.
Okay. Okay. Yes. Okay. Welcome. I think today we are starting on the diseases of the liver. Obviously, we cannot do everything. We shall do as much as we are able, but that doesn't limit you on reading other diseases that we have not discussed. We are doing the inflammatory conditions today and some of the common pathways of chronic liver disease. And then next time we shall be looking at malignancies, other disease processes. Next week we shall be looking at cirrhosis and liver hepatocellular carcinoma. That doesn't begin to cover all there is about liver disease, but it gives you on the whole an extensive approach to most of the diseases that you're going to encounter. And it ties in with what you're doing in internal medicine. So you may encounter some of the issues discussed in internal medicine that we have also tackled from the pathology point of view. The idea is to appreciate that it's the same patient, same disease, approached from the science point of view, what we see when we make the diagnosis, while internal medicine, they're approaching it from the point of view of managing the patient. Otherwise, it's all extensive. If you're able to synthesize that as one, well and good. And then when it comes to answer questions, because that's where the problems come in, if I ask you about liver cirrhosis in pathology, and Professor Gutu asks you about liver cirrhosis in internal medicine, there are those things he's more interested in. Well, for me, the other end that I'm interested in, although you don't lose marks for mentioning what the other individual may be more interested in. So it's just to be wise, who's asking the question? Where is the emphasis? And of course, for us, etiology, pathogenesis, and what we see as the pathology is more critical than how the patient presented. A mark for the patient, the way the patient presented, a few complications, but more on the pathology of the disease, which would be the opposite of what the rest would be interested in. Okay, if it agrees to move. Okay, so you have to go back. To understand the liver and the digestive system, you have to go back to anatomy and the physiology. And once you understand the anatomy and the physiology, the disease falls into place readily. So some of you have already rotated with us, others are still to rotate. We go back to the normal of liver, and the liver is a large organ. It's one of the large organs in the body. It's about 1.5, so it's a reference range of about 1,400 to 1,600 grams. And it takes about 2% of the total body weight. So you can see it's a fairly large organ. And it's one of the organs that can be damaged, traumatic injury. In fact, when one has an accident and there's trauma of the liver, that is serious. And the surgeons will be concentrating on such pathologies, trauma. But you will see that we are not talking very much about trauma. Yet, when you come for postmortems and you find the forensic ones, you'll find that that is one of the critical injuries, if missed, leads to death in a patient who has had motor vehicle or some traumatic incident. So because it's a large organ, when injured, it can bleed very easily and cause massive hemorrhage. Okay, so the blood supply, it gets 60 to 70% through the portal vein. Remember, we talked about double blood supply when we were talking about infarctions last year, the general principles. The liver is fairly, what shall I say? It's we don't talk much of infarction in the liver. This is because it has two blood supplies, the portal vein and the hepatic artery. And the portal vein supplies most of the blood, 70%, while the portal 60 to 70, while the other one is about 30 to 40%. So you would have to block both to result in infarction that we can recognize in the liver. Unlike the spleen, which has an end artery, where we are able to see infarction readily. So liver and lung are well protected. Of course, that is not 100%. You can get unusual disease processes, especially of the vessels. Okay, for the liver, we talk of the unit being a lobule and an acini. I think that you've already done in anatomy and physiology. And so when we're talking about the disease of the liver, all the activities around the disease process from the pathology point of view is around the lobule or the acini. And the reference point is the portal triad and the surrounding. Okay, the etiology are diverse, just like you've already done in the heart and the respiratory system, the cardiovascular and the respiratory system. We have metabolic. Metabolic comes in when you're talking of liver and kidney. Metabolic is important. The liver is a key organ in the metabolism, be it metabolism of fat, metabolism of carbohydrates, metabolism of vitamins, all those, and another important element of drugs, metabolism of drugs and toxins. You can ingest something which is not harmful, it's metabolized, and the metabolite is harmful. And because of that, the liver is one organ that gets damaged when you're not careful how you administer medication. So when you are prescribing, one has to be careful because if the liver is not functioning, some of the drugs may be injurious to the liver and precipitate a hepatocellular failure. When you breach more than 80% and you tip a person into hepatocellular failure. Okay, we have infections. It can be affected by all types of infections. Viral, hepatitis B, you've already had. Hepatitis C, which is becoming important. And then many other viruses, including yellow fever, which we have in our country, and all sorts of other organisms, bacterial, fungal, and when we have disseminated issues. It's not a common sight for the COVID so far. We have not heard of it being affected much, but I believe it's a matter of time. We shall find out that some patients, when histologies were done, they were able to demonstrate this virus there, and it added on to the complications in the lungs. So the liver is also a target of all sorts of organisms affecting it. Some provoke precise types of pathology, like when we come to schistosomiasis. It's a very interesting disease where adults live in the liver and you get all sorts of effects because of the eggs. Okay, so infections, all varieties of infections, and for them to have a significant effect, they have to destroy a large part of it, or it has to be a diffuse kind of damage for us to see that. Then we have toxins, ingested and otherwise, that can damage the liver when people ingest toxins without knowing, and they have metabolites that are injurious, the liver gets affected. It can have circulatory and neoplastic issues. Circulatory, when we have especially the portal vein undergoing thrombosis. That's a common problem. We may not go so much into that, but you may hear a lot from the internal medicine end. Liver has a large reserve for decompensation. I don't think we can overemphasize this. We talked of the heart, which compensates when you do persistent high blood pressures. Now we have a liver here, which has a very large reserve. 20% of the liver is enough to maintain a steady state. Damage more than 80%, where now you have less than 20 functioning and you get decompensated. So that means to have come from 100% as created by God to whatever damages that happen over time because of the exposures that we have. Exposure number 1, exposure number 2, somebody drinks, we shall see how all those affects. And then you get exposed to malaria or something else, and collectively they overwhelm the liver. So we only need 20% to be functioning for it to produce a steady state. And of course, now if you get a chronic liver disease that only leaves a 20% reserve, it means it's very easy to be tipped over. Liver is key. Everything you ingest, it will feel it. And therefore, when somebody is at that steady state of where there's no reserve, it means it's easy to tip them over. Even normal things like Panadol, taking paracetamol, can tip them over into failure. Okay, of course, we don't have a machine where you can put the patient and clean up like the kidneys. You have to start thinking of transplant. We don't do much of that in the country, but we have people who are interested in that. Okay, it's interesting. If you go back to the principles of how cells are arranged in space and how cells are defined, detecting the substances contained within the cytoplasm and the membranes that are released when the cells are injured, it is possible to do a biochemical detection and monitoring to see how much of the liver is destroyed. So if you've never been interested in chemistry, this is where you will see how chemistry is useful. We can tell somebody who looks okay, you know, brags to the people how much he drinks, but when we do a biochemical test, we can tell that there's been some damage because there's an increase in a particular analyte that is linked to damage to liver. And therefore, we can predict that if they continue like that, then they are bound to have problems. Okay, so chemistry here, liver function tests. I challenge you, if you're rotating with us or have rotated with us, liver function tests. Now you want to connect. What does that mean? Early detection of liver damage, acute damage, chronic damage. It all relates to structural damage. How much of the cell is damaged and what disease process damages, for you to be able to detect biochemically that there's some form of damage. It's very interesting. When you look at the chemistry, specific analytes tell you what kind of damage there is and what disease process that is likely to be. So that becomes exciting if you like chemistry. Injury can involve the cell both from the functional point of view, where chemistry would be able to detect, and structural, where we would be able to detect when a biopsy is done. Nobody runs to do a liver biopsy. We only run to do a liver biopsy if we think the damage is large, or if we think there's an ongoing something that we can help halt or reduce or diagnose. Otherwise, most of the time, the diagnosis will be functional using biochemical tests and also radiological imaging. Okay, we get scenarios where a large portion of the liver cells are damaged, and so we talk of liver cell necrosis. Individual liver cell necrosis happens all the time with inflammatory metabolic conditions, but it becomes critical when it becomes massive, because that's where you can have sudden hepatocellular failure because of massive cell necrosis. And massive cell necrosis, mortality is very high. What are the things that can do this? Toxins and some metabolites. Okay, of course, inflammations that are not infection related. You can get inflammatory conditions, immunological, and of course now we diagnose using immunological techniques to try and demonstrate that the hepatocellular damage is immunological. So you can get inflammations where the person has either jaundice, persistent jaundice, you can tell what is happening, or they actually have deranged liver function tests, and these deranged liver function tests are not linked to any of the other things, but an immune-induced inflammation. Then, of course, being plastic tissue reactive, then we see regeneration and fibrosis. And for the liver, if there's derangement of the structure, as anatomic pathologists, the structure of the liver is critical. So if we see that there's derangement of the beautiful liver plates that we see when we do normal histology, then we know even function and vasculature of blood flow within the liver will be affected and therefore cause some hemodynamics. And liver being an organ receiving a lot of blood flow within it, coming from the rest of the abdomen, then you realize that we end up with other issues like ascites and the complications there. So it may regenerate back to the normal size, but function may be lost, and that may create other disease processes, which I think we shall discuss next week, the cirrhosis, which is different from fibrosis, as we shall see. So what that means, we'll be able to discuss most, but toxins, you'll hear more chemistry, metabolic, more from what you already from biochemistry and from internal medicine, but the rest that define the functional and structural changes that we see, we'll be able to discuss. Okay, so we start with inflammatory conditions. And when you talk of inflammatory conditions in the liver, viral infections are important. And why are viral infections important? Because we have a variety of them. They affect diffusely. They don't do a localized thing. They do a diffuse infection, and they are much more common than the rest of the conditions that one can talk about, except for metabolic derangements following other secondary diseases. Okay, and we have both viruses that are localized in the liver and others that are not basically localized in the liver, but still are able to damage the liver. So we call them hepatotrophic viruses and other non-hepatotrophic viruses. And which ones are these hepatotrophic viruses? Here we go back to hepatitis B, C, E, G, and whatever else that has been discovered. I don't think we've reached the end of it. And here you hear more of the viral effects in immunology and medical microbiology. And what are the ones of interest? Hepatitis A. Why is this important? In a country like ours, where the sewerage system is wanting, even in a capital city like this one, every now and then we get outbreaks of this hepatitis A viral infection. Some years back, we had an outbreak, or there was a burger place here in town where we had several patients coming, including colleagues and students. They went and ate there, and they would be admitted with jaundice. And after testing, would find that they have hepatitis A. And when people took history, we were able to localize one of the joints in town. I don't know what the public health guys eventually found out. That time I was working in the wards, but we were able to isolate an eatery where people were getting infected with hepatitis A. So it's an orophycal transmission, and it can result because of contamination of drinking water, that is drinking water being contaminated by sewage, are common happenings. In fact, when I see people going to buy, I hope we don't have guys here going to buy eggs and sausages at the gate. We have guys who go to eat sausages at the gate. You have to ask yourself where those guys go. Do they use the med school toilets? Do they use Kenyatta National? Where do they go? Where do they wash their little trolleys that they boil eggs? And you have to be careful. As a health personnel, when I see students, because I've seen a few, mainly the MTC ones, but I guess even the med school ones are there, I get shocked because hepatitis A is only a small thing they would get. The other worse ones that they can get when you eat things, and we are not sure whether food handlers tests have been done to confirm that these guys are okay, or they are feeding us hepatitis A. Okay, then we have hepatitis B. Hepatitis B is of interest because it's parenteral. The main area of concern, which would be through blood, we have taken care of. So if you've been to the hematology or the immunology place, you know that we screen for hepatitis B in our blood. The blood donors must be screened. And as medical students, we urge you to have vaccination before you come to the wards. Hepatitis B is even more infectious than HIV. And if you're going to go into our mortuaries or any of the areas where we are dealing with blood, you better be vaccinated. And you must get all your 3 shots so that you get the correct protection. So hepatitis B can be transmitted through blood, and it is also can be a sexual transmission, and you can also have a horizontal transmission. In our setup, it occurs early in life. We get quite a bit. In fact, if you look at the map of hepatitis B, we are among the regions with the highest transmissions of this hepatitis B. So I urge you to go back to the immunology of hepatitis B, go back to the microbiology of hepatitis B, or these hepatotrophic viruses. I would urge you to go back to those viruses. It will help you link what we are doing today with what hepatitis B is. One of the critical viruses for the anatomic pathologist when we are looking at the biopsies of chronic liver disease. Most of the time we get involved when somebody has a chronic liver disease as confirmed on imaging, confirmed with the biochemistry or clinical chemistry, liver function test, and we come in to try and show whether there's this damage that could be giving the derangement that they are seeing. So by the time they are coming to us, there's much more that has happened. There's serology which has been done and all that. That's why I'm encouraging you, if you can, please go and review hepatitis B. It's an interesting virus to study, and it has interesting pathologies. Okay, then besides that it's one of the common things that even made us have a childhood vaccination program. When we started, we never used to have it, but it became a childhood vaccination program. So when you rotate in 4th year next year, you will see that it's one of the things that we give our children. And we try to booster, like for you when you come here, and people who work in hospitals and such like places. So it's an important virus, and it costs the country quite a bit because of the chronicity. Then we have hepatitis C. Hepatitis C is more common in the West, but we have a bit of it in our setup, and it's also being screened in some of the centers, if not all. So hepatitis C is also important, and it is even more, it has more severe liver changes than hepatitis B. But because we have an overwhelming majority of patients having hepatitis B as opposed to hepatitis C, so we see more of patients with B. But when you see C, it has more severe damages to the liver. Then, of course, we have the others that are associated, hepatitis D, which is coexists with hepatitis B, and it can also create similar scenarios to hepatitis B. And one way we demonstrate that a person has hepatitis B is we can also do immunohistochemistry on the tissues that we have been brought, so that we try to confirm which are the viruses. But even before we do that, we do serology, and we are able to tell what is going on. There's hepatitis E. It's become important in blood donors. They've started screening it, and hepatitis G. You even know more of them. The liver pathologies are not as well defined as A, B, and C. A doesn't have much except in early disease, but B and C are well defined, and of course D coexists with B. We have other viruses such as yellow fever, which require the liver for replication. CMV, when we have disseminated CMV, you can get liver derangements or liver function test derangements because of disseminated infection affecting the liver. CMV can go all over. And then we, of course, have EBV. We are in the part of the world where EBV is high, and we fear EBV because not only does it give us infectious mononucleosis, then later we start talking of Burkitt's, start talking of non-Hodgkin's lymphoma, and of course, even sinonasal tumors. Then it's a herpes, and the other herpes viruses, and then adenoviruses as well. Okay, so a little bit more about these viruses, especially the ones that we are likely to encounter messing the liver. People rarely die from hepatitis A, but unfortunately, a few can get overwhelming infection, get hepatocellular failure, and they are knocked off. Not common, but it does happen. Okay, it is a single-strand piconovirus of the genus Hepatovirus, Fico-Oro, like I had said, a very benign disease, but unfortunately, as a witness, I have seen some having bad disease and even ending up badly. It does not cause chronic hepatitis or carrier state, but what is feared most is if you get a patient who gets severe disease. Of course, they will have liver derangements and we'll be able to see acute changes in the liver. Not chronic, but acute changes in the liver. So not a subject of anatomic pathology much, but a significant contributor to deranged liver function tests in patients who are being investigated. Hepatitis B is one of interest to us, DNA double-strand virus. It has a long incubation period of about 1 month to 4 months. So somebody just starts feeling hapa badly, malaise, and it can go up to 4 months before the disease is clearly defined. But because we do investigations, like I told you, as the liver cells are being damaged, something is being discharged into the bloodstream, and it can be picked up by our chemistry tests. Okay, and the interesting part, because it's a chronic disease, it has all sorts of presentations. We can get acute hepatitis, very acute, and the patient comes, and thereafter becomes a carrier or recovers. 90% recover, 70% actually have subclinical infection. They don't know, but if you tested them, you find they're positive. And then another 30% present with jaundice. They have yellowness of eyes. When malaria was more common, we had to rule out malaria first. But now you have to think hepatitis B. But however, hepatitis B is a chronic thing. You still have to consider malaria. We haven't eliminated malaria, just suppressed it, but not eliminated it. Okay, the most feared part is when you get now a more severe form, which we call fulminant, in that it progresses very rapidly. A fulminant hepatitis, a severe hepatitis, and with massive liver cell necrosis. Instead of a chronic damage of liver cells bits by bits, this one damages a lot of it at one go and causes massive liver cell necrosis. You can imagine when you have massive liver cell necrosis of a critical organ in the metabolism. Of course, the patient is not in a good state. Usually, this is diagnosed with a patient in the wards very seriously off. And when we're talking of fulminant, we're not talking 1, 2, 3 days. It takes a while, even when you consider it like that, because this is a chronic disease. It's not like an acute hepatitis, pyogenic related, which we are not even considering today. Okay, a small percent of them may end up with death or complications requiring a transplant. It's not a common thing in our setup to have transplants, but in India, they do quite a bit of transplants. And I know in the country, we have people who are interested to start doing transplants, not because of hepatitis B, but because we have other bigger things that produce more chronic liver disease than hepatitis B. Okay, another small percent, we get non-progressive chronic hepatitis. It's just there, not progressing, but if you do biopsy, if you do serum chemistry, then you're able to see derangements, but it doesn't progress, it remains the same. So it's called non-progressive. But within the liver, you have a chronic inflammatory infiltrate, and there's it remains there and does not get cleared, like the 90 who recover. Okay, then we have another group that progresses. So it is active and it's progressing, and we are able to show that they continue to damage the liver cells. And because of this progressive chronic disease, it leads to healing with fibrosis and distortion, because the liver is a stable type tissue which can regenerate. When it is damaged, there's a provocation to regenerate. And when that happens, you get a sum total of healing with fibrosis and regeneration. Cirrhosis is a topic of for next week. Eh? And when that happens, you get the mass restored, but function and structure deranged. So it's not good. It's not a good thing. And if it continues, then or the same cirrhosis, a small percent progress and may develop hepatocellular carcinoma. Of course, in between, they can go into failure because of the damage. And then a few they're not even aware they have it. They just know they have it the day you decide to screen them. And these are called asymptomatic carrier state. They give us a lot of headache in the labs. When you decide to do hepatitis B surface antigen, and then a person is positive and they can't even recall. And those are the ones who recover without knowing they got it. Okay, what are the potential outcomes after that infection? We have discussed a few of these, but what are those now listed down? Those who have subclinical disease, they have it, but they are not aware, or you might see a tinge of jaundice if you are very keen as a clinician, or you may do a test for whatever reason. They went to donate blood, you had a pre-donation screen, and you find that they have this. 100% recover, which is good news. Okay, the acute hepatitis, 99% are the acute hepatitis, and only 1% become fulminant. So it's a very small percent that progress into a terrible scenario where the mortality is pretty high. And then the chronic hepatitis, majority will recover, a few will get cirrhosis, a small percent will get hepatocellular carcinoma, and some may die from it, or others may actually go for transplant because of cirrhosis, not hepatocellular carcinoma, but because of cirrhosis. We have not been doing too much of liver transplants as we do for kidney. Okay, so how does one get this virus? It's a virus of interest for us because of, like I said, I think we were ranging between, there was a time we were doing 5%. I'm told now we are less than 5% in the blood donor. Just guys who are well, who have come to donate. When we do the surface antigen, we actually find, I think, is it 3%, something like that. So you can confirm that in hematology. There was a time we were doing even up to 5% of positivity. The childhood vaccination has really helped us. Awareness has helped, whereas before, most of the transmission was horizontal. You're born by a mother with hepatitis B, or one child acquires, and then as they are playing around, they get whatever. But it can also be a vertical transmission. Okay, so most of the people get infected during perinatal period, either during birth or soon after. And 90% of this happens in the high prevalence areas, and our country happens to be in that category of high prevalence areas. Quite a bit is horizontal, not vertical. Quite a bit is horizontal and not vertical. Okay, early childhood is dominant. in intermediate prevalence areas, they get it later, not perinatal period, later. And then there's a very small percent which is sexually transmitted, and God forbid, intravenous. Intravenous sharing injection, when we never used to, when we were recycling needles, although we were sterilizing. So if you found a careless worker, then you could inject people and produce. So intravenous, whatever, and this happens in areas that have low transmission rates, like the West. And then, of course, transfusion, God forbid that we give somebody hepatitis B because of not careful screening. A few years ago, it was not even a requirement in all the centers. Some of the centers were not screening hepatitis B. We were screening hepatitis B in the towns, but now it's mandatory, it's a requirement. It's no wonder we had such high rates. Okay, of course, it's just the same thing as HIV, blood transmitted infections. So we don't expect a significant percent to be in this. Unfortunately, we have various people who are using drugs where they inject. So that could fuel that, but we don't expect it to influence the country so much. But when you think that it is sexually transmitted, it can be horizontal. So even if you have a few IV drug users, then they can influence the rest of our rates by their behavior. But screening has really helped, that nobody should give blood that has not been screened, because we have a national transfusion service, which was meant to reduce that. Because if somebody gets a chronic liver disease, it wastes our national resources in the health sector, which would have used for other things. Therefore, screening is cheaper than trying to treat one chronic patient. Okay, it is a adenovirus, and we have 8 genotypes of this virus. And because of that, we have a variety of proteins that help us monitor what is happening in the patient, whether they're in the active phase, whether they have recovered, or whether the virus is replicating. And that happens because we are able to detect the various proteins, the ones I have highlighted in yellow. So we have the core antigen, which directs the secretion of hepatitis C antigen, and all this can be acid. When you're rotating in immunology, take note that we don't always screen for all of them, and we usually screen depending on what the clinician is looking for, whether the patient has active viral replication, because the implication is that we can give serum, we can give immune serum, or we can give some other medications to reduce that. And that happens when they're following patients who they can't explain what is going on, and so they try to monitor what is really happening. Then there are some who can be very infectious, as denoted, but whatever it is. And the surface antigen, they have recovered and they are non-infective. They just show that they have been exposed, the system has contained the virus, and they are non-infective. However, we don't transfuse people with this blood. We don't usually, when it's positive, we don't use it. Then we have the ones who have the DNA related to the D, and it is possible to also detect it and say whether it is there, whether antibodies are being produced. We can detect both the antigen and the antibodies, and they are all proteins, and it is possible to do lab tests. And there's a chart we usually share that shows how the various antigens and antibodies are rising and falling, waxing and waning, and they give you an idea as to what is happening to the virus. And that is really not of much interest to me as anatomic pathology, Mine, I would be interested in demonstrating hepatitis B surface antigen in the cells. When we demonstrate hepatitis B surface antigen in the cells, besides the tissue reaction, then we can say yes, the chronic hepatitis the viral chronic hepatitis that we are seeing is driven by hepatitis B or hepatitis C or any other virus that we look out for. Okay, what are the serum markers? These are of interest and they are repeated everywhere. They're repeated in chemistry, we repeated them in immunology, and the med-micro guys will talk about it. So serum markers, hepatitis B surface antigen, that is the easiest to check, and it is seen before the onset of symptoms in the incubation period as the virus is replicating. That's when there's maximum production of the surface antigen, and then it declines when the virus stops replicating and can become undetectable. Unfortunately, we have some guys who remain positive and they indicate a carrier state. But when we are able to elicit an antibody response, then we know we can also be able to detect an antibody response to the surface antigen. So we can also detect the antibody. Okay, and that is what we call the anti-hepatitis B surface antigen, antibody to this antigen, surface antigen. And it is seen in the acute disease. Okay, it is seen when the acute disease resolves and after the disappearance of the antigen. The antigen provokes formation of the antibody. And so when we start seeing the antibody, the antigen is also disappearing. And it can persist for life, actually. The antibody can persist also for life. And it is a good indication that the person is recovering. Okay, we can also confirm whether it is an IgM, and you know those are the ones that are produced early. And usually we are looking for the one against the core, and that is the one that is related to hepatitis D, the hepatitis D. So it is seen shortly. It can be detected before the onset of the symptoms and after the hepatitis B surface antigen. And there's also derangement of serum enzymes that indicate that there's damage to the liver. And that happens because as the virus is replicating, for the virons to be released, the particles to be released, there has to be damage to the cells so that they can be released and go infect more cells. And because of that, the serum, the liver enzymes are bound to the lysosomes, and when there's destruction, they are released, and therefore they can be detected as a marker when we do liver function tests. What is the other one? Hepatitis B DNA polymerase. The DNA itself and the polymerase chain, it can also be detected, and this appear after the hepatitis B disappears. The hepatitis B surface antigen disappears, and then one is able to detect the E, that is the envelope antigen, and the DNA to the hepatitis B, and as well as the DNA of the polymerase that is associated with hepatitis D. When there's persistence of the E antigen, that implies that the virus is still replicating. So sometimes we will be asked to detect a particular something because of what they're trying to demonstrate in the patient. So they may come and ask, these are not routine tests. The routine test is the hepatitis B surface antigen. But they may ask us to do these tests if they think that the patient is not able to shed the virus completely, and they want to see predict whether this patient is progressing to chronic liver disease. Why is that important? Because if you know somebody is progressing to chronic liver disease, then you have to warn them so that if they drink or they expose themselves to other issues that will compound the chronicity, then you give them the information and they make their choices. Of course, anti-hepatitis E antibodies imply it's an acute infection which has peaked and is now on the decline. So there's quite a bit on these serum markers. You can read about them because they have implication on how you follow patients with hepatitis B. Have they cleared, are they say infectious? Are they still replicating the virus? And how to proceed? And this is critical in my patient management, not in diagnosis for us, but serology. And serology can be done in immunology or in other of those clinical pathology disciplines. Then we have hepatitis B. Hepatitis B is important to us because we see the most severe liver pathology when it is the C. We don't see quite a bit of it in our setup, but when we detect it in the patients and they do biopsies, we actually see more destruction of liver. The chronicity is higher in these patients and their outcomes are not good. If the patients get the hepatitis C, they're more prone to become chronic and they're more prone to progress into cirrhosis and even hepatocellular carcinoma. So we would pray that this doesn't become the dominant virus in our setup, because our problems would be compounded. Our problems would be compounded. We have too many etiologic agents for chronic liver diseases that we would not want to add hepatitis C to our setup. I think we see less than 1% in the donors, and even in the clinical practice, it's not a common virus. Every now and then we have scenarios where they suspect it, and when we look at the biopsy, we see more damage. Of course, it becomes tricky because the definitive diagnosis is that we must demonstrate the virus within the liver cells. It is a single-strand RNA virus, flaviviridae. It's not a virus like the other one. This is a flaviviridae, and a single strand has a shorter incubation period, but more prone to chronicity. The parenteral transmission, especially in IV drug users, is more common than hepatitis B, and also sexually transmitted. In some centers, they say that it is also the more common one in the medical workers by virtue of the occupation. I pray that we don't have that. Nobody has done a study to see whether we have a higher rates of hepatitis C in medical workers than not. Most of the times, the ones we see, you'll hear that the person has traveled to has lived in other parts of the world besides ours. And of course, the world is a village, and you've seen that from the coronavirus transmission. Okay, in other parts of the world, it contributes a significant proportion of chronic disease, but for us, because of hepatitis B, because of aflatoxin, because of alcohol, it's not as important, but an important cause of chronic liver disease. Like I said, chronic disease and hepatocellular carcinoma. So it's more prone to progress into those two nasty scenarios as opposed to hepatitis B. So, and it also has a persistent infection and chronic hepatitis compared to hepatitis B. Okay, then we have the hepatitis, the hepatitis D delta agent, and this is it's a defective virus that cannot survive on its own. It requires hepatitis B, and therefore it's always a co-infection. In fact, people have worked out what kind of percentages some populations have who have a co-infection with hepatitis D or the Delta agent. It cannot infect on its own. It requires to be transmitted with hepatitis B, and it's a self-limiting, although it gives a more acute problem, and it is seen in IV drug users. It gives more of acute liver failure, but can also be seen together with hepatitis B when we are looking at the chronic liver disease. It can be the cause of acute hepatitis in somebody who had hepatitis B that was not recognized. It can be the cause of the acute exacerbation, and especially in somebody who has been known or has been diagnosed to have chronic hepatitis B. They can have, it can be an exacerbation or cause an acute problem. More common in IV drug users. We pray that we don't go that route. They say those who've had multiple transfusions that can also end up with it. It's not usually our common way of management, but as we refine treatments, I'm sure we are just going to experience whatever the rest of the world is experiencing. Detecting the antibody, the IgM antibody to hepatitis D virus is what is considered to be a most indicative of exposure to hepatitis D in the patients suspected to have it. And we are saying that they will already be having a chronic liver disease, but getting exacerbations or acute episodes in the background of a chronic one, then you have to wonder whether they have acquired the Delta agent. Then we have the E. E is very much like A. It's fecal-oral, enterically transmitted, waterborne, can be an epidemic, usually in the young, the children, and the middle-aged adults. It's thought to be a zoonotic disease and can have a high mortality rate in women who are pregnant. Usually these fecal-oral ones are not so bad, but every now and then they can be a nuisance. This one is a problem in the pregnant. In fact, there's an interest in screening for it in donors. There's an increased interest in trying to screen for this virus in the donors. A few people are advocating that we should also be screening for this. So you may hear about hepatitis E virus and the serology because of the interest in hematology in terms of donors. We don't see much of the liver disease is not marked. We don't see much damage. This one mirrors actually hepatitis A, but now because of it being detected in blood and thought to have some other significant effects that were not recognized before, it is said that we have several viruses that have not yet been diagnosed. Earlier, these ones were just propositions. Now they have become well defined and they are even being detected. And people are trying to produce kits even for using them to detect in serum. Okay, so viruses of interest that might become significant in the future, but when it comes to causing acute or chronic liver disease, not yet, but probably will become important in the future. Okay, so what happens when has a viral hepatitis, regardless of which virus one is dealing with? Of course, we've said some are more severe than others in the damage and in the chronicity. So what do we see? Because we come in at the biopsy level. What do we see when we get a biopsy? Or if it is a postmortem that one has been involved in, of course, what happens is that if there's history that a person has active hepatitis B, C disease, we don't do an open biopsy. We do limited, like the MITS that Dr. Walong does. So we take a liver biopsy and look at it. We don't open up because hepatitis B is highly transmissible. And people have shown that it remains transmissible even on our postmortem rooms. It remains viable even after we have cleaned up. If you notice, we don't allow you guys to come and start just doing postmortems. One of the reasons is to protect you from some of these viral diseases that have been shown to remain viable on postmortem slabs. So this is what we see when we suspect, if we are given a history, or if we suspect that is hepatitis B, don't be surprised that we don't open up. What we do just a small cut through the abdomen on the right side and take liver, and we take a liver biopsy. We take a liver biopsy and look at it under the microscope. And these are the things that we watch out for. In the inflammatory infiltrate, nobody is going to biopsy a liver where we are expecting to see a neutrophilic infiltrate. That might happen if somebody has septicemia. So nobody's gonna do a biopsy for that. You wait for the disease to resolve. But if a person has been having symptoms, we've said that these are chronic diseases, months actually, takes weeks and months. And therefore, if they're not getting better despite medications, then they may decide to do a liver biopsy to determine whether it's a treatable cause or not a treatable cause. Okay, so when we are brought to the biopsy, we look for retention of the architecture and what is infiltrating the cells. So we see scanty mononuclear infiltrate. What are the mononuclear infiltrate? We're talking of lymphocytes, plasma cells. Macrophages are harder to detect, but mostly lymphocytes and plasma cells. When we see liver cell necrosis, you may see a few macrophages coming into play. Okay, so we get mononuclear infiltrate. There may be hepatocellular damage, parenchymal injury, and we notice that as a periportal or damage of the cells in the periphery of the acini and lobule, especially the lobule. So we see necrosis or even apoptosis, where you get the cells dying off, shrinking, so that you just see it as a shrunken, small, pycnotic thing. And then we might also see spotty liver cell necrosis. That is where you see within the lobules. You see an inflammation within the lobules and a few cells dying off. But most of the time we look for them around the portal triads. That's where we look for it, and then it can bridge from one triad to another. So you see the liver falling off on either side. Then we see degeneration of the hepatocytes, and the degeneration we see is they balloon out. Hepatocytes they have a characteristic shape, but when we start seeing them rounding off, they usually have a squarish appearance. But when we start getting them ballooning out and rounding off, then we talk of balloon degeneration. Why? As the virus is replicating, is damaging the cell, and that allows some form of ballooning of the cell. And then we might now see the entire cell shrunken, or some are ballooned and some are shrunken, apoptotic bodies. We sometimes see some of the liver cells having very eosinophilic cytoplasm. And if you recall cell injury, when you're getting damage of the cytoplasmic content, then there's release of all those membranous breaking down membranous bounding membranes and the contents, and therefore it takes up a lot of eosin and looks pink. So we talk of eosinophilic hepatocytes, and they may even have a epikinotic nucleus or even a fragmented nucleus, meaning that there's now more damage to the nucleus. We've moved from cytoplasmic damage to nuclear damage. Because of what is happening being a viral infection, the lymphocytes that are attracted to the site are T cells, the cells that come to damage the infested or infected hepatocytes. So you get an inflammatory infiltrate of lymphocytes, and these lymphocytes are the T cell type. Sometimes we get necrosis, which can be confluent around the central vein. The central vein defines the lobule, and the bridging between the triads defines the acini, the unit of the liver that functions, through which the blood flows and through which things diffuse. And therefore, when we're looking at the disease processes, we look at the lobules and the acini, because from the pattern of infiltration and damage to the hepatocytes, then we are able to relate which disease process that is. So we get necrosis around the central veins, and it can be marked when in severe acute hepatitis, like when we are getting the Delta agent infecting one who has an underlying liver disease. If the damage isn't too much, but provokes healing with fibrosis, when you damage hepatocytes, they regenerate. When you damage and there's architectural, if there's a breakdown of the architectural framework so that the regeneration isn't perfect, then what happens is that you get fibrous tissue. And when you get fibrous tissue coming, then it means the intricate arrangement of the vasculature of the portal vein and its branches and the hepatic artery and its branches, then you end up with a hemodynamic derangement that now creates other problems that we shall see when you get the portal hypertension. And that happens because as the hepatocytes are being damaged around the triads, then you find that there's healing with fibrosis and distortion of the vessels. And that creates a background bleed, a background pressure that does not allow free flow of blood and creates portal hypertension. And that becomes the long-term sequelae of this chronic disease. In fact, it's not the immediate effects that are so bad, it's the long-term effects, the cirrhosis, the portal hypertension, and the increased risk of developing hepatocellular carcinoma, which is one of the tumors with a high mortality rate. Okay, so a periportal chronic inflammatory infiltrate that damages all the hepatocytes around it, and you end up with healing with fibrosis. And when that happens, we talk of interface hepatitis. We have the lobular hepatitis and the interface. The interface is around the acini, the lobular is around the lobules. The lobules are defined around a central vein. So you have to go back to your anatomy. If you don't remember anatomy, you remind yourself, because we are able to define either around lobular arrangement or acina arrangement. The way you look at breast, the way you look at salivary gland, you talk of lobules, acini. So even for the liver, those are defined that way. And they're important because for the anatomic pathologists, they help define the disease process of what we are seeing. Of course, if it is severe, you end up with scarring. The liver framework is reticulin, and therefore, When reticulin, which is fine, is replaced by dense collagenous tissue, you end up with scarring. And you get ductular reaction where you get a proliferation of the bile ductules, and a clear-cut cirrhosis where you get regeneration of liver cells, but they are not arranged in the lobular acinar arrangement. You just get these nodules of cells regenerating, surrounded by this fibrous scarring tissue. And the cells are there, but the hemodynamics are disturbed. And we are talking of a metabolic organ that has to discharge all these things into this vasculature, and therefore even function is compromised. The vasculature is compromised, and which is the structural vasculature compromise, and that results in functional compromise. And of course, that is terrible because it leads to hepatocellular failure. If the liver fails to detoxify things and produce things, then you also end up with functional failure. How do the liver cells look like? Hepatitis B is a DNA virus, and because it's a DNA virus, it's incorporated into the host DNA. And because of that, it's like the HPVs that you talk about. There's transformation of the cell. And the biggest transformation that we recognize is the ground glass appearance of the nucleus, not the cytoplasm, the nucleus. Some viruses cause nucleic changes, others cause cytoplasmic changes. With hepatitis B, because of the incorporation into host cell, and especially the nuclear part, because it's a DNA virus, then we are able to see ground glass appearance. It looks like the opaque glass that is put in toilets so that you can't see through, the person can see you through. That's what the ground glass appearance is. It's an opaque something, and that is because the cell has the viral particles. In chronic hepatitis B, it creates an interesting scenario where there's marked reaction with formation of germinal follicles. So if we get a liver biopsy and we see lymphoid follicles, germinal follicles, and a very marked fatty change, where you get storage of fat within the hepatocytes, then we know hepatitis C is a differential, not necessarily hepatitis B, but a hepatitis C, and then we alert the doctors for them to confirm. Why? Then you know what kind of prognosis to expect, because we are seeing that hepatitis C has a poorer outcome. Okay, then we come to this entity. This is an interesting entity, fulminant hepatitis. And what is the definition of this fulminant hepatitis? Fulminant hepatitis is when you get massive damage of liver by the infecting agent, so that you have a shrunken liver. We said that originally it should be about 1,500 grams, 1.5 kgs. And here you are, from between 14 to 1,600, you end up with a third of that, 500 grams, 700 grams. When we have that, we talk of fulminant hepatitis with massive necrosis. So the first thing that tells us there could be a fulminant hepatitis is the weight of the organ. Of course, if imaging has been done, even then they notice that there's a shrunken liver, and we know we can get a shrunken liver in cirrhosis, but it doesn't go that low. It doesn't go that low. So if we get 500 grams, 700 grams with the history of hepatitis and deranged liver function test, confirmed on serology that there's presence of either the viral antigen or the viral antibodies to the virus parts and components, then we know that we have a scenario where the infective agent has caused massive damage to the level that only a third of the liver is remaining. When we look at it grossly, we see necrotic areas of hemorrhage, we see areas of bile staining, and we also see collapsed reticulin network. And we can confirm that on microscopy. And then if for some reason the patient survives, it has a very high mortality. Fulminant hepatitis, somebody who gets a viral infection, be it hepatitis B, hepatitis A, but more of hepatitis B and C, if they get a fulminant infection that affects most of the liver, majority die. A very small recover with problems. And when we find a few surviving patients and we have to take biopsies, then we find that they have inflammatory infiltrate with collapsed architectural framework of the liver, and then we see a few regenerating nodules. I've never had to deal with somebody who has recovered fully and survived long. Most of the ones I get are the ones who are being diagnosed before they die, or they had liver disease. They were not sure whether it was drug-induced or it started as viral and precipitated by drugs and ended up being fulminant, and they want us to confirm. So the ones I've seen are postmortem material. I have not had to deal with life issue, but I have seen postmortem scenarios. Okay, so those were viral. You can get all those that we've talked about, what we see, and the other scenario, which is nasty, where you have a fulminant hepatitis. Okay, what are the other infections that one can get? We can get bacterial infections. When you consider that we probably have more bacterial infections bringing people to hospital, it is amazing that we don't have so many of them who are coming because they have bacterial infection affecting the liver. The hepatotrophic viral infections are worse because they're the ones that bring the patients as the primary reason. The others that affect are secondary matters. Somebody was known to have immunosuppression for whatever reason, HIV, transplant, and what have you, and now you end up with dissemination, and for some reason they do a liver biopsy, and then we see things like CMV. Okay, but all the same, we do have other infections, and they can present as the only thing, and for whatever reason, and the patient has to be diagnosed. And what are these? Usually they are septicemias, and which irritate the liver. So you get a mild hepatic inflammation and deranged liver functions, and especially the jaundice part. And so they decide to do a liver biopsy, and we show that it is, or they confirm that they already had and they think that the liver has been affected. So it's not a diagnosis we do. Nobody will be doing a diagnosis to confirm. But every now and then, we do have disseminated miliary tuberculosis where they are not sure what is happening. And then the person presents with liver issues. And when we do the biopsy, we find that they have granulomas. So we do get a few, not common, but a few, where they are not sure what's happening because they have not connected miliary from elsewhere, and they think it's a liver disease. And when they bring, we tell them it's miliary tuberculosis, or we are seeing granulomas, and they go back and they say, oh yeah, bone marrow was done, there was miliary. So, they continue. So not a primary liver disease, but something they happen to be testing. Okay, we can get direct spread of pyogenic organisms like Staph aureus, in toxic shock syndrome. We can get it in those who have salmonella and lodging, actually going through the gallbladder and lodging in the liver. We can also get syphilis. We can get cases of syphilis, secondary, especially disseminated, nobody knows. And then there's liver derangement, And when you do, actually, you have to demonstrate that you have Treponema pallidum within the liver cells. We are able to decipher if we see a marked plasma cell reaction within the liver, and note that we have macrophages that have ingested organisms, and then confirm that it's Treponema. And we can confirm on special stains, or we can request a blood test to be done, or even a CAN test to be done, VDRL, all those. But usually from the reaction in the liver, we may suspect, or they may even be suspecting. Of course, it can be also enterobacteriose reaction through an ascending cholangitis. Anything through the GIT, ascending, cholangitis, extending to the liver. The other interesting ones are the abscesses. We can get a pyogenic abscess as a direct spread, or multiple when it is a vascular spread, and it will lodge in whichever lobe, depending where it is coming from. The patient usually present with right upper quadrant pain. It can be a hepatomegaly, because remember there's rapid multiplication of the organism, destruction of the hepatocytes, accumulation of pus in that site. And it can be painful and even cause fever because of the pyrogens that are being released. And we put needles through liver swellings. So usually when we have a swelling which has fluid, is it blood? Is it pus? Is it amoebic? Those are differentials. And we can do cytology, and from there, they're able to drain or even resect the cavity. But they don't resect while it's active. They have to give antibiotics, because if it was a single direct spread and it's not yet sepsis, you don't want to create a sepsis. Of course, the rest of the liver is okay, unlike in chronic hepatitis, which is a diffuse disease. This will be a localized area damaging, and we say that the liver, 20% can function well. So if the liver is occupied, the abscess is occupying what percent? 20% of the liver, then the rest of the 80% is still there to function. So these ones usually don't have derangements. They don't have derangements. They actually have mass effects, or the pyrogen effect. When they are large, the surgeons drain them or resect that part of the abscess. And of course, because the abscess, there's healing in the periphery, healing with fibrosis. Usually you will see a thick-walled fibrous wall, and then the cavity is shaggy. And it can even be more shaggier when we are talking of amoeba. When you have invasive amoeba usually just causes diarrhea. But when it starts invading colon, it's carried along to the liver and creates an abscess, then you have issues. And obviously these abscesses can rupture into the liver, not in liver, into the lung on the right side, and create another system trouble. So you start with a GIT, goes to the liver, goes to the respiratory, or just abscess in the liver, rupturing in the lungs, and creating more of a crisis. So sometimes they require surgical, medical and surgical intervention. Okay, another interesting organism that we must talk about, schistosomiasis. Schistosomiasis is a parasitic infection. This is where you go back to your biology of parasites. I don't know whether you studied in second year or in third year. Wherever I've written pots, I'm indicating that we have beautiful pots. We don't have a good shrunken liver. I don't know, we never preserved that. But we have good pots of these diseases that we are talking about. Pyogenic liver abscesses, go and see them. We don't get them readily. You might never see another one put in a pot. Then come these other nasty disease. People think this is a small disease, but it can create havoc when it is not managed well. Why am I talking about this one? You've heard of the orphan diseases, emerging, re-emerging diseases, forgotten diseases, tropical diseases. These schistose are among those ones. And as future medics, you have to do your part. We had done very well in trying to control schistosomiasis. You have seen that we are having more and more areas in the country coming under irrigation. And as we do irrigation, I imagine some of you are going to see some of these cases. We saw many of them as students, then we stopped seeing. And now I'm seeing them as a pathologist, early disease, not liver. I'm seeing it while it is still intestinal or bladder. And what is happening? We've become very adventurous. Tourists within our country, which is very good. You are helping the service industry. And then you go and play with water, you don't know what kind of waters you are playing with. We've had patients who've gone and swim Lake Malawi, Lake Victoria, Kenyan side, Ugandan side, Tanzania side, it doesn't matter. We've seen patients from all those countries. They swam Lake Victoria, Kenyan side, some swam from the Ugandan side, some went to the Tanzanian side, and they all come with the same schisto, Lake Malawi, Tanganyika. And then others have never gone to waters, they deny that they have come across, they don't deal with the rice, they don't grow rice. So we are lost. Southern Sudan, we have some of you training in our institutions, and we have some of you who will work in Southern Sudan. Unfortunately, this disease is coming back. I don't know how much of it you are told in parasitology, but I am worried because we shall now eventually start seeing what we were not seeing in the liver. I don't know how much of this is being seen by the surgeons and internal medicine, but we are seeing from pathology point of view, we are diagnosing early schistosomiasis before it becomes complicated in the liver. And what happens? People go to swim in the contaminated water and they get miracidium, and they the Saccharys, who get into the system and lodge in the liver. When they lodge in the liver, Saccharys is the one in the water. Miracidium is the one gets into the, or the other way around. And what happens is that you get the organisms and a pair lodges either in the portal veins or even in the ones of the spine. But now we are talking about liver. So you get a pair living in the portal veins, a male and a female living together. These are big creatures. They are big organisms. You can see with your naked eye. And they will survive for many years. All they do is take up the blood, extract the hemoglobin from the red cells. I mean, they survive there, and they become prolific in producing eggs. We are told a pair can produce thousands of eggs. Go back to your parasite and remember, how many can one pair produce in a lifetime? They don't die in a year to what? We don't take medication to kill them. Eh? It's not, if you want to deal with them, it's not the everyday medication that we take that kills them. So they live there, they produce eggs, the eggs have to continue the cycle. So when they're going through the intestines, that's when you hear somebody had diarrhea, so a bit of blood, they took medication, or they ran for colonoscopy. Our endoscopic guys are very busy. They do colonoscopy and they bring us biopsy, which has a schisto. At that stage, it has no effect. But as this pair continues to produce eggs, as the eggs are migrating through the walls of the portal veins, they provoke an intense immunologic reaction. The adults don't provoke. They actually don't have an immunologic response. Their offsprings, which go as eggs, migrating through the venous circulation, provoke an intense immune type 4 reaction. The type 4 reaction is the tuberculous type, granulomatous reaction. The granulomatous reaction is destructive and causes formation of fibrous tissue. So we get fibrous tissue around the vessels. Intense fibrous tissue around the vessel, it hardens the vessel and creates what we call a pipe stem fibrosis. So you see it surrounded by a thing around it that gives a pipe stem fibrosis. Blood vessels have elastic tissue, so they should be able to expand and reduce as the blood flows. But with fibrosis, they become stiff and create hypertension. They create increased pressure, which becomes hypertension, and somebody ends up with portal hypertension and the consequences of portal hypertension. You can't die from this, but the consequences of this pipe stem fibrosis is portal hypertension, varices, and somebody can bleed massive hemorrhage, can have massive hematemesis that they die as you watch. That's the drama of schisto. Unfortunately, this disease is doing a comeback. So if somebody comes to you, take a history. We have had people deny, and then when they get convicted, they bring the whole family because they don't know where they went and played with water. When people say we must have pools that are chlorinated and you have maintained them the right way, is to avoid these kind of things. Somebody will go and pee in the pool and they have urinary schisto. And if you didn't put chemicals, then you're creating adults who will have portal hypertension, who will end up with massive hematemesis and die. And maybe they are productive members of society. So it is very sad that a disease we could have handled is coming back. Some countries have done campaigns of treating everybody, what have you. Well, if some of you go into public health, please help us. This nasty disease is doing a comeback. As pathologists, we are worried because we are seeing it in its early stage when the eggs are being discharged through the colon and the bladder. Some talk of hematuria. The urological guys do biopsies. We see eggs. And we know next they will end up with this. Especially if you don't take care, we don't have to diagnose schisto with biopsies. It just requires a stool and urine. Those are simple tests done even by the basics of the labs. But unfortunately now we are diagnosing them as a histology. And that is an area of concern. So far, I haven't had my colleagues talk of pipe stem fibrosis at postmortem, but it's going, those who are going to be surgeons, those who are going to be internal medicine guys, you are going to treat these guys. In another 10, 20 years, you'll be treating these guys we've been diagnosing. Why? Because we don't give them enough attention. They stop having the diarrhea, they stop seeing the blood in urine, and later they now present with the complications. Pay attention to the patients that you see. Some have had hematuria and turns out cancer, but now we have this, which is treatable. So please pay attention to some of the things that we ignore. And it is because of an immune response that causes a distortion of the architecture, not of the small vasculature, as we did with the viral hepatitis, but with the large vessels. The large vessels, resistance, pulling back, involving the spleen and portal hypertension, which now results in a We have a beautiful pot with with the pipe stem fibrosis due to schistosomiasis. Okay, we do have the other forgotten, often emerging things. So if you continue eating things at the gate, this is the other one you have to worry about. If you escape hepatitis A, then you might not escape amoeba. And amoeba is a protozoa infection, a large creature, single cell, able to ingest red cells, choose red cells. But when when it's intestinal, all it does is just live on bacteria. Then for some reason, they suddenly start invading the intestines. They cause amoebic dysentery, where there's bleeding in stool from just a diarrhea. You suddenly have dysentery. Schisto is a cause of dysentery. Amoeba is a cause of dysentery. Shigella, Salmonella cause dysentery. But now amoeba, once it starts causing dysentery, it now is carried along into the liver because they invade the liver, the colon, get carried along in the lymphatic channels. As the macrophages are being carried along, some amoebae, trophozoites are carried along. And when they are carried along, they lodge in the liver and they start digesting the liver. These ones, just as they digest the red cells in the colon, they start digesting liver tissues. And they create an abscess that rivals pyogenic abscess. And you may not tell the difference, but it actually creates a pyogenic abscess. We have a pyogenic abscess in the liver, in the museum, and we have an amoebic liver abscess in the museum. Have a look at them and try to see if you can see the differences. One is more destructive, so shaggy and may be able to see. We've had a few cases where they suspect it. You can imagine by the time we escape diagnosing it in stool, colon biopsy, and now we come to liver aspirate. We've had a few cases where we've had to diagnose. We see a cavity with necrotic debris, and then you see the trophozoites in the wall. So we've seen trophozoites of amoeba doing their thing, digesting liver tissue and creating large cavities that can also rupture into the lung and create problems in the lungs. And they do that because the trophozoites, not the cysts. The cysts are not a problem. The trophozoites are the problem. The active forms, they spread because they digest through the liver, causing undermining flask-shaped abscesses, and then they are carried along into the liver. Not long ago, we found a patient who had obstruction of the cecum. It's very rare to get the cecum obstructed. A few large tumors can do that, but this one had obstruction of the cecum and ascending colon, and we thought it was tumor, but when we went there, we found that they had an amoeboma. So we have an interesting thing in the museum of amoeboma, where the person didn't have good immunity and trophozoite proliferated and created edematous wall that even caused obstruction. So these trophozoites then lodge in the liver and digest and create a cavity. The necrotic debris that they create is characteristic brown, and those who know how this fish sauce looks like, it resembles that anchovy sauce. And like you said, it can rupture into the whatever. And we've had a few. I have been involved in a few FNAs where we've had to confirm trophozoites within an amoebic cavity. Of course, it's tragic when we reach that scenario. Things we can take care of, we fail taking care of them, and then they come to compete with malignancies. Okay, we do have other organisms. Of course, you know the story of malaria and what it does, how it multiplies in the liver. The schizones multiply in the liver, and we don't usually have liver biopsies. Liver will be enlarged, there'll be some derangement, they'll have jaundice and some derangements. And then we have hydatid cyst. Hydatid cyst is interesting because you can get a large cyst within the liver. You can get multiple, you can get one in the liver, another one in the lung, or you can get in another odd site. And this hydatid cyst, if you're suspecting them, you have to be careful, because whereas we can aspirate this one, we don't go aspirating this, because we can create anaphylactic shock. This one has to be resected out by the surgeon, while this other one we can aspirate and whatever. So the index of suspicion have to be clear. And if we aspirate and not cause anaphylactic shock, then you may cause seeding, because it has daughter cysts. And it's a form of a tapeworm that can create a problem within a cestode, that can create problems within the liver. So we do have hydatid cysts. They have characteristic whitish gray cyst wall, and within the fluid, we have daughter cysts that are easy to define. So these organisms, just as you saw them in parasitology, we see them in the tissues. And if we suspect them in liver, we can have the same. Of course, this is usually easy to recognize. If for some reason the person was given medication somehow, substandard, didn't complete, then we are able to recognize it on microscopy. But gross appearance, this is the easiest to diagnose, and pipe stem fibrosis. Okay, so those were infections, quite a handful. Should the country still be grappling with things we should have eliminated? Judge for yourselves. Should the county use money to deal with those things when they could be paying you better salaries? If you become a public health specialist, tafadhali do your job so that there's more money for increasing salaries, not fighting things which you can teach people and they learn to deal with. Okay, now comes here this other one. Another major problem in our setup, alcoholic liver disease. What do we do with alcoholic liver disease? This is a major problem because it causes a metabolic problem in the liver. Liver is key in the metabolism of alcohol, and it has a spectrum of effects that it causes in the liver. Next week, we shall see some of those common pathways where chronic hepatitis and chronic metabolic liver diseases, including alcoholic liver disease, have a common pathway. Just like lung diseases have a common pathway of causing chronic lung disease. Even the liver, all these organs have a chronic common pathway. You start with one thing here and there, but then they reach a stage where they all look alike, and it takes a while to determine what created that final scenario that we are dealing with. Okay, so alcohol is a social drug. People don't condemn it. Some think it's a nice thing to do. The other day we were shown young students drinking it like juice, and you just sympathize because you know what lies ahead. It has its psychological issues, it has its all. In fact, I tell my students that alcohol can affect any part of the body. Today we are talking about the liver. Tomorrow you'll be talking about pancreas. Somebody else will be talking about stomach. And this alcohol has effects in all these areas. When you come to psychiatry and CNS, it has effects in the brain. I mean, you know, it's a terrible thing that it's quite popular world over. Okay, in the liver, what are some of the things that it can cause? And even before we go on, let me say that it's not drinking alcohol once in a while or drinking in moderation that gives you what we are talking about. This is being depraved and having no control. In fact, everything that we use that brings disease is when we lose control. When we lose control on what we are eating, when we lose control on what we are smoking, those are the kind of things that create disease processes. So even alcohol, it's when there's no moderation that one ends up with some of these derangements that we shall be talking about. And so what format can it take? The easiest reversible is fatty change. And fatty change is called steatosis, hepatic steatosis. It's reversible if one abstains, the fatty acids will be metabolized, and that's the end of the story. We just get fatty change because the fatty acids are being stored in the liver to be metabolized. And of course, when you burden the liver with that kind of thing, you compromise its function. You continue doing that, you get damage, and of course, you start talking cirrhosis. Of course, that means that it's been there. It would have to have been there for quite a while. Okay, before you get to that chronic stage, one deals with a scenario where there's damage in the liver, so that you now talk of steatohepatitis. There's a chronic inflammatory infiltrate, not just storage. Fatty change is storage. Steatohepatitis is storage. Just the way we see in the guys with obesity. They start with storing fat, then damaging because there's too much the hepatocytes rupture, provoke an inflammatory response, as steatohepatitis. Okay, so that's the progression. A fatty change, and then it continues. If you remember the story of fatty change, starve yourself for 3 days, you have fatty change. Why? Liver is a key organ in metabolism. That's where things are converted from one thing to the other for energy. So they get stored there. So that's not a bad thing. But it continues, then you have problems. And the problems can arise with healing with fibrosis. Why is that bad? Destruction of architecture, derangement of the vasculature, and the consequences. Okay, so when we have steatohepatitis, you get ballooning, they lose the shape. There's death of some of them, necrosis. They provoke inflammation and accumulation within the site and distortion. We can see some recognizable breakdown products which appear eosinophilic. They are called Mallory-Denk bodies, and they accumulate, although they are associated with other diseases, not just alcohol. But we used to think Mallory bodies are just associated with alcohol, but they're associated with anything that causes disruption and destruction. And there is eosinophilic bodies where the cell has died off, and it's just the cytoplasmic contents. It may provoke a neutrophilic accumulation around the bodies, or it may not, or the inflammation may be limited. Not a thing to worry about, the fatty change. Okay, if that doesn't stop, then now we come to other problems. Before we get to the other problems, what is the pathogenesis? We said that if there's excessive alcohol consumption. And what is excessive? We are talking of 80 grams, which translates to 6 beers or 8 ounces of 80 proof liquor. Those are the spirits. The spirits, like whiskey and the others. And even for 1 day to several days, you start getting mild steatosis. If it's more than that, and you know there are people who brag how he must take his 6 beers, 8 beers daily. If it's more than that, we get increased risk of damage. Increased risk of damage provokes a tissue response that may provoke a healing with fibrosis. What one wants to avoid is healing with fibrosis. And so long as the hepatocytes are being damaged, then there's healing with fibrosis. If they're not being damaged, if they're just storing that. This is very personal specific. Two people could be drinking the same amounts, one gets, the other one doesn't. There are many host factors, and I think Dr. Ndungu goes into a lot of details when you did that. Okay, and they say that the feared cirrhosis, only 10 to 15% of the chronic alcoholics actually get it. That's where the host factors come in, other mitigating factors that have been studied, and you can read about them. How do we demonstrate at postmortem? If you find a liver that is not red, dark red, and appears yellowish, there's some fatty change there. If you're buying a liver in the butchery, it looks a bit yellow, there's a bit of fatty change. The animal might have starved and what have you, or there's fattening of the animals. But in the human being, it's fatty. And if you want to demonstrate, you just, as you're putting it on the formalin, it will float. But if it doesn't float, then we don't have much of it. Of course, there are degrees of steatosis, which we must demonstrate. It is said that females are more affected than men. So drinking the same amounts, the ladies who want to be equal to the men, unfortunately, our bodies are not similar, right? So you have to be careful. You don't have to imitate everything that men are doing. God created men and women, and there's a difference in the way that the body handles alcohol, even if you think the rest is equal. When it comes to handling alcohol, men and women are different. So the women are more readily affected than the women. And it is thought that the estrogen has an effect in the metabolism, so that it encourages more and more storage and pro-inflammatory cytokines and chemokines. It's been shown ethnic differences. In our country, we don't know whether our different ethnic communities have, or whether it's the exposure. One day, one of you will do those studies, and we shall see, do the different communities have different effects. But in the West, they have shown that the African Americans are more affected than the whites in the US. We don't know, is it also other social, but them, they have said that it is actually the ratio differences. Genetic factors. In twin studies, it has shown that there's also environmental factor, not just the genetic thing, but also the environmental factors, and then also whether one has inherited this gene, which is defective and has problems in detoxifying or in the metabolism of the alcohol dehydrogenase, which requires that enzyme. So if you have the defective, you can't separate whether it is the gene differences or whether it is the environmental differences. Comorbidities. We are so unlucky. Not only do we have high rates of hepatitis B, we have aflatoxin in the maize we are eating. Some parts of the country are raining and they haven't harvested their maize. Then you just know our soils have aflatoxin. You hear the stories in Ukambani, some parts of Mount Kenya region, and the Rift Valley not so much, but eastern, let me say eastern, we have areas which have aflatoxin. So when you hear people are harvesting and it's raining, then we expect an outbreak of toxicity with aflatoxin. So now imagine there's somebody with scenario hepatitis B, aflatoxin, and then they go invite alcohol. We have high rates of liver disease, and it's because of these comorbidities that we are talking about. Okay, the steatosis results in dysfunction of the mitochondria and the cellular membrane, and that causes hypoxia and oxidative stress. It is all in the metabolism. Here goes back to biochemistry, how the liver handles various metabolites and various things, the Krebs cycles, the who, whatnot. There's a lot of shift from this to that, and the liver is involved in all that. And that is because there's a lot of substrate from the metabolism of the alcohol, and it ends up being stored as free fatty acids within the hepatocytes. Can it be stored in other organs? Mainly the liver, but it can also be stored in other organs. But basically, the liver. The liver is the main organ, but it can also, free fatty acids can also be stored in other organs. And of course, the more fatty acids stored, that obviously compromises the functioning of the cells, and therefore the optimal function is deranged. Okay, the accumulation of acetaldehyde causes lipid peroxidation and of course damage to the cytoskeletal and membrane dysfunction. A lot of biochemistry as to how that happens. But where is the interest for me? Accumulation of this can be demonstrated. It affects the way the organ looks, it affects the way the cell looks, and it damages the structure. And when there's that damage, we know that inflammation follows, and when inflammation follows, we have consequences. Of course, when the inflammation follows, it's much easier to demonstrate. Otherwise, most of the time you'll see a bit of fatty change here, fatty change there. But when we have the subsequent effects of disrupted membranes and that provokes inflammation, then we are able to see defined changes that can help us say that this is steatohepatitis, as opposed to this is steatosis. But there's a lot of biochemistry involved in the causation of what we see. And of course, then we come to this stellate cell of Ito, which is important because when there's provocation of these cells, then we provoke fibrosis. I said the liver cells are held in place with fine reticulin, but when the cells are provoked, they lead into fibrosis. And what happens is that now we end up with vascular derangement or disturbed blood flow, and we end up with cirrhosis and hypertension, sinusoidal hypertension. But this cell is key in the next stage where we get cirrhosis. What is the clinical presentation of a person who has fatty change because of, or has alcoholic fatty change? Because you can have other fatty changes, even pregnancy can induce fatty change, toxins can induce fatty change. So we are talking of alcoholic fatty change or alcoholic steatosis, alcoholic steatohepatitis. What are the clinical presentation? A large liver. So long as you are depositing something in the hepatocytes, the liver becomes large, hepatomegaly. So when you're palpating, you palpate a large liver. Because there isn't much destruction, there may be mild derangement. And what you see is raised bilirubin and alkaline phosphatase. If it becomes severe, then it's unusual to become severe, but if it becomes severe, then you get the other liver test derangements. But the ones that are initially deranged are bilirubin and alkaline phos. This is the story of the chemistry guys, so they will tell you even better, and you can connect the dots. They may have malaise. When people have liver disease, they usually have malaise. They may have anorexia, can't tolerate fatty foods. They may have weight loss and even upper abdominal discomfort. So the liver is impinging on the stomach. They can't eat much. They already have the effects of alcohol on the throat, they can't swallow. So alcoholics have a lot of problems, but today we are limiting ourselves to the liver, and therefore, those are some of the things that we talk about. What are the lab findings? Hyperbilirubinemia. Not from the chemistry end, you'll be told the ranges of which disease to consider. Those are fine details which you can learn for yourself. But for our purposes, there will be increased bilirubin because the liver can't handle as well as it should because of this increased storage of free fatty acids. Increased alkaline force, we've said. Serum aspartate transaminase may also be raised, but that is the ratio of the two. And there may be, interestingly, a neutrophilia. There may be a neutrophilia. We say that we can get damage around some of these hepatocytes and you get a neutrophilic response. So there could also be a neutrophilia. They can also have cholestatic syndrome. They just have jaundice, which doesn't disappear regardless of what they do, even when they stop. So they can have a cholestatic syndrome. And they can also have repeated bouts of the same. It comes and goes, or just the syndrome. And of course, when it is severe, that would really have to be a very unusual, sad scenario. But they will not just go direct from steatosis to cirrhosis. They will end up through alcoholic hepatitis. They would end up with alcoholic hepatitis and then eventually cirrhosis. But severe fatty change can also lead to cirrhosis. Then, of course, they can get the cirrhosis now. They can get portal hypertension because of healing with fibrosis and disturbance of the hemodynamics. They can get hepatocellular failure because a lot of the liver is affected beyond the 20% that needs to be functional. And then they can also eventually get carcinoma. So we shall be looking at this next time, I believe. I don't think it's today. How much do we have? Okay, so we have the final one. The next topic we shall be looking at this because this is a common pathway of any chronic liver disease, viral, drugs. You realize we can't even talk about toxins and drugs. The problems that can result, hepatotoxic drugs. So when you're giving people drugs and they're hepatotoxic and somebody already has a deranged liver, then you have to be careful, okay? So that's what I would advise, that you be careful when you're doing that. So this is a common pathway which we shall be talking about next. What have I done? Okay, what are some of the outcomes? If there's abstinence, they will have no jaundice, no is it a derangement where it shouldn't be the? Okay, I think this one we shall discuss next time. It will make more sense. Let's continue this next time, because from fatty change, then now you get to alcoholic hepatitis, and from alcoholic hepatitis, then you get the common pathway of chronic liver disease. And I don't have to discuss this here because that will apply with all of those. Okay, that brings us to the end. Wow, it's a long one. If we're in the lab now, you'd be looking at the slides and the pots. We usually have the lectures and then we now look at the slides and the pots, where I would be able to show you some of this. I think in the next lecture, I have a few of the images that I want to show you, and we shall be able to share. Okay, let's see if there are any, where am I? Let's see if there are any comments or clarifications in the chat. Yeah, that they say is for somebody's asking about the glass of wine for the heart, not for the liver. To the liver, it's an fault. But to the heart, it's a good. The heart guys will say that. The liver guys might not agree. Okay, if there are any comments, I think next week it might be lighter, and therefore we can continue the discussion. Because we've done a few of the causes, and now we shall be converging into a common outcome of these chronic diseases, which if you had a chance, you would want to avoid. Chronic liver diseases are terrible because you either have a liver transplant, and if you have never seen this, those who are rotating in internal medicine, maybe you have gone to the clinics and you've seen the liver clinic where we have all sorts of patients with deranged liver functions. They are miserable patients because you cannot put them on dialysis like the other patients. You can't replace the liver function unless you bring another liver. And nobody has come up with a machine that can be used to do what the liver does. They are miserable patients. Okay, so if there's no comment, then you can